So right now we're going to talk about these ROC curves. What is happening here, what the different values are for everything, and why it's set up the way it is. And to actually get a good idea of the why, we also need to look at these things right here, and we'll kind of look into that really quickly. Before I deal with the ROC curves, I really want to talk about these kinds of biases because they're getting more and more important. Not just what they are, but how you deal with them. All right. Anyone can, of course, um, think of, oh, well, obviously the information was poorly measured. Okay, but the test is going to actually test you on what solutions do you want to use. So let's just go through all of these, and then we'll talk about the Roc curves. So selection bias. Obviously, you did not do a good job selecting who you're selecting. And you have a couple sub-examples here. The people that you're controlling from are from a hospital and are not as healthy as the normal population. So everyone's just dropping like flies or something. Or they have exposures that are different to that of the general population. And attrition bias. Everyone ends up leaving, and so the people you have left isn't really applicable in terms of giving the study some sort of significance. So how do you reduce it? You randomize. And you do a good job of choosing people. Recall bias. Okay, so this is something you see all the time in retrospective studies, and it's not entirely clear when you first read it what it's talking about. But here's a good example. All right, you've got a bunch of women, and you ask them, hey, did any of you drink during pregnancy? And they all go like, oh, no, 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 no. But then some of them who ended up having kids with disabilities say, oh my God, that explains everything. At 38 weeks, I had a sip of alcohol. That's what. Okay, and there we go. People who have certain results will end up recalling things differently than those who don't. All right, so that's kind of the awareness of the disorder comes in. Okay, so what do? You just hit them up way later. All right. Of course, measurement bias. You did a bad job measuring. Right? Similar to how selection bias is, you did a bad job selecting. Measurement bias, it's implicit in the name. You did a bad job measuring. Okay. And then there's the Hawthorne effect, which is kind of like the effect of everything's all cool and dandy, and then someone whips out a video camera and you start acting a little bit differently because you know you're being recorded. All right. These two last ones are probably the most important, and it has to do with the importance of masking and placebo groups. So of course you should have subjects treated the same in different groups. Even when you look at something like crossover studies, eventually they all take the same thing. And then of course observer expectancy bias. This is just, you kind of expect one thing, so you do things to ensure that that happens. It's kind of like when you're convinced of something, you'll kind of act in a way to reinforce your own belief. And that actually does happen, and it messes up the validity of experiments. So make sure you are properly blinded and that you use placebos. Anyway, so let's go right here into the Roc curves, okay? So the important thing to look at is that the true positive rate is equal to sensitivity. Always keep that in mind because that's gonna influence everything. All right. I really hope this is on. I have no idea. Anyway, let's take a look at a cool site. So this is a great site, and it kind of tells you what's going on with everything. But let's try and answer some questions here, okay? So right here, this is telling you, okay, these are the people without something. And in red, you have the people with something. Okay. And so what we're kind of testing of course, is a test. We're looking at this test and its sensitivity and its specificity. Okay, and just like in the previous example, we saw on the bottom we had the false positive rate, and on the top we had the true positive rate, or we can also just call that the sensitivity. Okay, remember, sensitivity, no means no. All right, so when we fiddle around with this thing, what we're doing is we're seeing how blended together our sample is, you know? And of course, this is talking about a test. So let's take a look at this test right here. This test right here, not bad, okay? You've got a bunch of people who are negative that the test is gonna probably test negative, and a bunch of people here where the test is probably gonna test them as positive, all right? However, depending on where we put our threshold, that's what the test is gonna say is positive or negative. So what happens when we put our threshold here? Well, we kind of maximize right here. So what we're doing is we're trying to maximize the sensitivity here, and we're trying to minimize at the same time the false positive rate. So let's try to understand things that can increase and decrease the false positive rate, okay? So I'm going to move this thing over a little bit, all right? And as we get more of these negatives blending into this positive, especially with this cutoff, you'll see that the false positive rate keeps getting closer and closer to this value right here is 1. All right? So when we keep moving, you'll see right here that as all these negatives whip out as positives, the false positive rate increases. Okay? Well, then what happens if we kind of make it go away? What happens to the false positive rate? Well, you'll see it decreases. So now you're wondering, well, okay, well, I got this thing all the way over here. You know, how can I make sure that you have, you know, only, well, how can I make sure that you have 100% sensitivity? How can I make sure that all the no's are actually no? And so the idea is that you would actually need a maxed out, oh no, a maxed out graph looking like this, where you have no overlap. All right, and that's where you'd be able to be at this point right here, where you are 100% sensitive. All right, and you have no false positives. Pretty straightforward. Okay, so what happens then if we mess around with our threshold? Okay, so let's say we've got a more normal looking curve or something. We put our threshold here. The idea is that in this test, we're saying everything here is going to be called a positive, and everything to the left of it is going to be called a negative. So just as you can see, right here, everything to the right, well, yeah, there's a bunch of positives. You also have some false positives here. Look, right here you have these blues that have kind of merged with the reds. These are negatives. Unfortunately, these are false positives. Okay, well, what can you say about some of these negatives here? You know, some of these things are going to be called negative, but they actually aren't negative. Well, you remember sensitivity means no, so what it means is a negative is actually a negative. So these negatives aren't actually negative right here. It's tested negative, of course, because it's to the left of the threshold, but it's not actually negative. And that's why you don't have this thing way out here in the corner. All right, let's actually keep looking and see what happens as we change this a little bit. Look, there are more and more things being called negative that aren't. The sensitivity is suffering more and more. This is all saying, hey, this is no, and it just ain't so. Are all of these no's? Not really. And you'll notice that at this point right here, all the yeses are true positives, okay? Because there's no blues. There's no actual patients who were tested positive but are negative. So that's why the false positive rate is right here at 0. But the sensitivity is suffering because you have all these people right here who are being tested and being told that, you know, they're not positive, that they're negative, But that's clearly not the case. Look at all these people here. Look at all these people here. Look at all these people right here. So this is unfortunately I guess a symptom of the way tests are made. It's really hard to get 100% specificity, 100% sensitivity in anything. And just one more time, in case you were wondering, what would we have to do to get this little red dot maxed out right here so we have 100% sensitivity? What would we have to do? Well, you would have to have no overlap. So that way all the negatives are negative and all the positives on the test are actually positive. And again, that would look like this. Okay. Thresholds are important because it lets you max out kind of your positioning here in your area under the curve, where your calculus comes back in handy, I guess. You'll see right here as we shift the threshold over to the right, the area under the curve suffers because we're not kind of maximizing the best of both worlds as we could. And as we shift it over here, the area under the curve also doesn't do so hot. Okay. So hopefully this has been at least a decent introduction into these Roc curves, how it plays into sensitivity and specificity, and the importance of the crossover here in terms of how many positives that are tested as a negative, and how many negatives that show up are tested as a positive, and how that affects your ideal placement and the area under the curve.